Hi, my name is Shellen Lee, and today I will be discussing orthopedic procedures, specifically radiographs of the knee. A knee x-ray is considered to be one of the top 5 procedures where the staff at UNC hospitals most often are making either positioning error or patient safety errors or image quality errors that lead to repeats. This is a learning module on how to properly take a knee radiograph and avoid making a repeat. Here is a diagram that shows the fundamental anatomy of the knee. The femur, patella, tibia, and fibula are the bones that make up the kneecap and will be captured on a knee radiograph. This slide lists the different projections of the knee that can be captured with x-rays. The anteroposterior or the AP view and the lateral view in the mediolateral position are typically the exams requested for most knee procedures at huge facilities like UNC Hospital. Many outpatient clinical sites, such as UNC Ambulatory Care Center and UNC Carolina Point 2, have a more elaborate set of procedures that involves weight-bearing procedures where the patient will be standing up. And you have AP, the intercondylar view, which includes the Cam Coventry, Beclaire, and Omblid, and then you also have the lateral view in medial lateral position. Most projections of the knee are taken at 44-inch source-to-image distance. This slide shows the different IR sizes for knee radiographs. The AP knee requires a 10 by 12 inch IR in lengthwise position. The lateral knee requires a 10 by 12 inch IR in lengthwise position. The oblique projection also requires a 10 by 12 inch IR in lengthwise position. The bilateral knee, which is basically an x-ray that captures both the right and left knee, requires a 14 by 17 inch IR in crosswise position. Some orthopedic clinics prefer using a 14 by 17 inch IR in lengthwise position for the AP, lateral, and oblique projections just to show more of the femur and tibia fibula. This is just part of their protocol. This slide explains how the AP knee radiograph is taken. So the patient body position is supine on the table, which means the patient is lying down on their back on the radiographic table with their legs fully extended, or the patient can be standing for the weight-bearing procedures with the back of their leg against the wall bucky. So for the AP knee, you want to rotate the patient's leg so that the intercondylar plane is parallel to the IR or table. The central ray is going to enter half an inch below the patellar apex. So the whole goal of this radiograph is to see open knee joint space. However, you can run into some problems because every patient is different and the central ray placement depends on the body habitus. For example, you want to measure the patient's top of the ACES to the IR or the radiographic table. So if that thickness is between 19 to 24 centimeters, then the central ray is going to be perpendicular to the IR. If that thickness is less than 19 centimeters, the central ray is going to be angled 3 to 5 degrees caudal, which means it's going to be angled towards the toes. If the thickness is greater than 24 centimeters, the central ray is going to be angled 3 to 5 degrees cephalic, which means the central ray will be angled towards the patient's head. So you just want to kind of eyeball as well and see how thick your patient is to get the right angle of the central ray, but they're all going to be entering half an inch below the patellar apex. Here are examples of AP knee radiographs. An AP knee radiograph can be repeated because it was not positioned properly, just like the example below. The one on the left is correctly positioned, whereas the one on the right could have been positioned better. The knee joint space on the left radiograph is clearly visible with the patella centered and slight overlap of the tibia and fibula. The knee joint space on the right is more difficult to see and could have been opened up a little more. This difference is due to the central ray placement and central ray not being angled properly for the radiograph on the right. The central ray was angled appropriately for the radiograph on the left, which opened up the knee joint space. It really all depends on the patient's body habitus and the thickness between the top of the ACES to the tabletop. The central ray needs to be angled more cephalic for the radiograph on the right to open up the knee joint space a little bit more. So for the lateral knee projection, the patient is going to be in lateral recumbent position, basically laying down, turned towards the affected leg with the knee flexed about 20 to 30 degrees. Or the patient will be standing for the weight-bearing procedures with the affected leg flexed and towards the wall bucky. So the patient is going to have to turn their leg in or out to get the intercondylar plane to be perpendicular to the IR or table. The central ray is going to enter 1 inch distal to the medial femoral epicondyle, basically right at the bend of the knee. The central ray is going to be angled 5 to 7 degrees cephalic or towards the head for all patients, regardless of their size, to superimpose the femoral condyles. This is because the medial femoral condyle is more distal than the lateral. So to get it superimposed, you have to add that 5 to 7 degrees cephalic angle. Some problems that you can run into when you're imaging a lateral knee would be that it's very difficult to get the correct profile of the knee because you have to get the femoral condyles to superimpose and you have to get a good lateral view of the patella as well and also have open knee joint space. Here are examples of lateral knee radiographs. A lateral knee radiograph can be repeated because it was not positioned properly, just like the example below. The one on the left is correctly positioned, whereas the one on the right could have been positioned better. The radiograph of the lateral knee on the left has the patient properly rotated towards the bucky with a 5 to 7 degree cephalic angle of the central ray, so that the femoral condyles are superimposed anteriorly and posteriorly, as well as inferiorly and superiorly. The radiograph of the lateral knee on the right does not have the femoral condyles superimposed. If you locate the abductor tubercle on the femur, which indicates the medial femoral condyle, you see that the medial condyle is more posterior than the lateral condyle on the radiograph on the right. Thus, the patient's knee would need to be rotated more towards the board and vice versa to fix the radiograph and take another one. These are the steps involved in an oblique knee projection. However, because these projections are very rare and are not even used at UNC facilities, I will not go into too much detail, but pretty much everything else is the same except you perform a medial rotation and a lateral rotation, both at 45 degrees. The lateral rotation best demonstrates the medial femoral condyle, the medial tibial condyle, and the medial rotation best demonstrates the lateral condyle of the femur and the lateral condyle of the tibia. The proximal tibia and fibula are not superimposed in the medial rotation. One of the intercondylar views would be the Camp Coventry view, which is performed when the patient can't stand, and so you have the patient prone or lying down on their stomach. The central ray is perpendicular to the tibia and fibula, and it enters the posterior knee joint, basically the back bend of the knee. The lower leg is flexed, usually about 40 to 50 degrees, and the foot rests on top of a sponge for support. And with this view, you can see the intercondylar fossa very well. Another intercondylar view would be called the Beclaire, and it's performed when the patient can't stand or be placed in prone position. So the patient is going to be in supine position, laying down on their back with their knee bent so that the femur creates about a 60-degree angle with the axis of the tibia and fibula. The IR is going to be placed under the knee on top of a sponge or sandbag for support, and you're going to have the central ray angled perpendicular to the long axis of the tibia and fibula, and it'll enter about half an inch below the patellar apex. This view is going to open up the intercondylar fossa for those patients who can't stand or lay on their stomach. Another type of intercondylar view would be called the Omblad method, and there's 3 ways of doing it. You can either have the patient standing with a vertical central ray, as shown on the bottom left-hand image, and then you can also have the patient standing with a horizontal central ray, shown as the middle image, and you can also have the patient kneeling on the radiographic table, shown on the bottom right image. but that's not really the ideal position for patients because that's very uncomfortable. Basically, the patient's affected knee is going to be flexed about 70 degrees from full extension and flat on the IR or Bucky unit. The central ray is going to be angled perpendicular to the long axis of the tibia and fibula, and it's going to enter the posterior knee at the bend. So why are knee radiographs popular for repeats? Well, you have the precise angle of knee rotation and a central ray to obtain clear open joints to consider. Patients also have varying body habitus, so you kind of have to eyeball your patient or even have to measure your patient to see how their bones are different. And even then, everybody's body structure is different, and you also have to consider pathology and trauma. Some patients might not be able to move a certain way, so that's why knee radiographs can be particularly difficult. Especially the lateral knee projections, weight bearing, are known to be one of the most repeated x ray exams due to positioning errors. Mostly because of the difficulty of having to get the femoral condyles to perfectly superimpose one another. Also, the angling of the central ray varies with patients, but you should have it about 5 to 7 degrees cephalic, entering at the bend of the knee. And then you also have trauma patients who may not be able to stand or bend their leg. So you'll have to do a cross table lateral projection, which might still be difficult for some patients. And that is the end of this learning module. Thank you so much.